Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm excited about today's episode because we'll be talking about pregnancy. At work, I look after our women's health content on MIMS Learning, and at home, both of my kids have just had their birthdays, so I've been reflecting on my own pregnancies. This episode's right up my street, and I hope you all enjoy it too, maybe coming away with some reflections of your own, as well as our usual top tips to take into your practice. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to the module version of this episode at mimslearning.co.uk to download your certificate. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and my colleagues are with me in the studio today.
Hi, I'm Pat Anderson.
And I'm Dawn Liz Powell.
And I have another special guest with us today, Chloe Harmon, who is the editor of our sister title, MIMS, the prescribing reference. Welcome to the podcast, Chloe.
Thanks, Rhiannon. It's great to be here.
I'll be talking to Chloe later on about a recent safety review by the MHRA into the anticonvulsant pyramate in pregnancy. I think we have to start this episode by thinking broadly about maternity care in the UK. And the maternity system has been really in the spotlight recently, hasn't it?
Yes, absolutely. And particularly in the run-up to the election. You may recall, for example, that the Green Party had to promise to conduct a review of its policy on maternity care after concerns were raised. It had said that there should be a reduction in medical interventions in childbirth and birth should be a, quote, normal and non-medical event. However, it had to backtrack on this after concerns were raised around safety for women and babies. And that came hot on the heels of an all-party parliamentary report on birth trauma, which said that there was a postcode lottery for maternity care, leading to very different outcomes, and it called for an overhaul of maternity care.
Well, I'm really fascinated by this because I had 2 low-risk pregnancies and my second baby was born at home. And so I had really positive experiences, but of course this isn't the case for everybody.
Well, sadly not, although it's good to hear you had positive experiences. But the inquiry into traumatic childbirth painted quite a different picture for some women. And as well as recommending more staff and better access to specialist maternal mental health services, it recommended the rollout of standardised post-birth services to ensure that the physical and psychological aspects of traumatic experiences were picked up.
We actually have a new module, Pat, just published, reflecting on exactly this point. It's on trauma-informed antenatal care, written by Kim Thomas, who's CEO of the Birth Trauma Association. And it's a fantastic module, gives some really powerful patient stories, as well as advice on how to care for pregnant women who might have experienced trauma, perhaps because of sexual abuse or trauma from a previous birth. And it also talks about how healthcare professionals can acknowledge trauma that they might have experienced themselves, for example, if they witnessed a traumatic birth.
I think it's just worth mentioning at this point that pregnancy itself can be traumatic, either because someone has struggled to get pregnant and or has experienced pregnancy loss before, or because they do not want to be pregnant at all, particularly if they've passed the point where they can do something about it.
So thinking about then where primary care fits in, GPs obviously haven't provided lead maternity services for many years, but studies have shown that pregnant women consult their GP more frequently than non-pregnant women do. So GPs are still important providers of care for women in pregnancy and postnatally. What are the key issues then, do we think, that GPs need to have in mind when they're managing a pregnant patient?
Well, pregnant people can still experience all the same health issues as non-pregnant people, but of course there are many more potential complications to consider.
So maybe thinking about red flags in pregnancy would be a good place for us to start because, of course, nobody wants to miss a serious condition.
Absolutely. And we have a module on this, which is updated by Dr. Pipin Singh. And it lists quite a long list of possible red flags in pregnancy, such as intractable vomiting, high fever, and leg swelling. You can find the long list in the module, but other red flags to look out for include severe back pain, visual changes, headaches, shoulder tip pain, unilateral pain in the pelvis or lower abdomen, vaginal bleeding, and reduced fetal movements. And some of the conditions to be aware of that can lead to these symptoms include ectopic pregnancy, DVT, pulmonary embolism, hyperemesis gravidarum, gestational diabetes, and pre-eclampsia. So there are a number of situations where you would refer urgently to obstetrics, of course, but this module also looks at how you should advise on things like fever, psychological issues, and even trips and falls in pregnant people.
Can I pick up on ectopic pregnancy then? We've got a learning module on this by Mr. Majid Abdul Rahman, who's our clinical advisor for women's health. And he says that the incidence of ectopic pregnancy in the UK has remained static for years at approximately 11 per 1,000 pregnancies. But the incidence in those using assisted reproductive technologies is nearer to 4%. And I was surprised to read as well that the etiology of ectopic pregnancy is uncertain, partly because it can't be studied in animals. It's virtually a unique human phenomenon. Ectopic pregnancies follow a benign course and they're managed successfully by surgical, medical or conservative approaches. But it does remain a dangerous condition with a significant mortality risk.
Okay, so what are the symptoms to look out for?
Well, women with ectopic pregnancy might present with symptoms of abdominal pain. Shoulder tip pain also occurs when blood irritates the diaphragm and stimulates the phrenic nerve. There might be amenorrhea or brown vaginal loss or fresh light bleeding. Heavy bleeding with clots, like the red flags that you mentioned, Pat, it's more likely to be a miscarriage. Diarrhea and vomiting are also symptoms of ectopic pregnancy that GPs might want to be aware of.
I've never been pregnant myself, but I'm sure anyone who has been pregnant knows that nausea and vomiting are common during pregnancy. In fact, they affect up to 90% of pregnant people. The severe form of nausea and vomiting, hyperemesis, affects up to 2% of pregnant women.
Yes, I understand it's a severe problem for some people, and I'm aware that the RCOG guidance on this has recently been updated.
Yeah, it has. So February this year, February 2024, the Green Top guideline was updated. And we are actually in the process of updating our learning module to reflect this. But the top line changes are that the new guideline discourages the suggestion of ginger to people with hyperemesis. And it advises that ketones should be reconsidered as a diagnostic tool for HG.
So hyperemesis is perhaps more of a clinical diagnosis then?
Yeah, that's the way it's going. Rather than relying on ketone measurements to determine management, it would be more of a looking at the symptoms and the impact on the patient's life.
Mm-hmm.
Our learning module covers the diagnostic criteria we've just talked about for hyperemesis and possible investigations such as full blood count to exclude infection and anemia, and urea and electrolytes to exclude hypokalemia, hyperkalemia, hyponatremia, dehydration, and renal disease. So the module says that the initial management of women with mild nausea and vomiting of pregnancy in the community is with antiemetics. But when community or primary care measures have failed, then ambulatory daycare management should be considered.
Thanks, Rhiannon. And talking about pre-eclampsia and going back to the red flags module that we discussed, I think you had a point about pre-eclampsia, Dawn?
Yes, I read in the red flags module that women who have developed hypertension while taking a combined oral contraceptive are at risk, as are those with autoimmune disorders.
So when would a clinician be suspicious of preeclampsia?
Well, according to the module, presenting symptoms might include epigastric pain, severe headaches, new onset visual problems, or sudden onset swelling. And NICE states that blood pressure measurement and urinalysis should be carried out at each antenatal visit to screen for preeclampsia.
And staying on the topic of preeclampsia, we have a module on diabetes in pregnancy, and this points out that maternal diabetes also increases the risk of preeclampsia. So the authors say that when HbA1c is expressed as a percentage, every 1% increment in the first trimester increases the risk of preeclampsia by 60%, which is an incredible amount. And the module adds that about 2 to 5% of UK pregnancies are affected by diabetes, and this includes pre-existing type 1 or type 2 diabetes as well as gestational diabetes. People who are living with obesity or have a South Asian, Black or African Caribbean or Middle Eastern background have an increased risk of gestational diabetes. And a key feature of management here is preconception counselling, and the module includes a helpful table listing the points you should cover in counselling, including tightening of glycemic control, stopping statins, ACE inhibitors and ARBs because they're contraindicated in pregnancy, and other advice for clinicians.
We do actually have a module on safer prescribing for chronic conditions in pregnancy, and we'll discuss that in a bit, but this does have more details on the safety of anti-diabetic therapy in pregnancy.
So in patients with type 1 diabetes, the authors say that tight glycemic control needs to be balanced against the risk of hypoglycemia, and a person needs to be educated about this. because most maternal deaths in the UK caused by diabetes are a result of hypoglycemia.
That's a really important point, I think, Pat, and something that clinicians need to be aware of. Embrace published figures in January 2024 showing that maternal death rates in the UK were at their highest levels in almost 20 years. That's 13.4 deaths per 100,000 maternities. And the module that we recently published on this has been really popular with our readers because it flags some pertinent points about inequalities in maternity care, which I'd like to just go over quickly. So Black women are almost 3 times more likely to die than white women. Asian women almost twice as likely to die as white women. And women living in the 20% most deprived areas had the highest maternal mortality rates, more than twice as high as the rate for women living in the 20% least deprived areas. And this module also outlines some lessons that health professionals could take into their practice to improve the situation. So, for example, it says that pregnancy is a good opportunity for professionals to promote other healthy behaviours like smoking cessation and weight loss, particularly for vulnerable women whose lives might be complex. And the report considers that women from ethnic minority backgrounds were disproportionately affected by COVID-19. And the pandemic really highlighted the vulnerability of pregnant women to infection with other illnesses such as flu as well as COVID. And this was exacerbated around confusion about immunisation and vaccine hesitancy.
And I'm right in thinking we had an episode on vaccine hesitancy on the podcast last week.
Absolutely. I interviewed Dr. Fazana Hussain on vaccine hesitancy, and I really enjoyed speaking to her about how she approached low vaccination rates among patients at her practice during COVID. Some of the insights that she got as to why the vaccine wasn't being taken up were really fascinating. So if you missed this episode, be sure to go back and listen. But back to the Embrace report, it noted that over half of the women who died in 2019 to 2021 were known to have pre-existing medical problems. Many had multiple underlying conditions. And the authors of the report said that many of the women who died from comorbidities, such as diabetes, as we've spoken about, were extremely vulnerable, but that there was evidence that the severity of their illness was not recognised during their pregnancy.
Just to add to that, on the topic of managing chronic conditions in pregnancy, we know that this can be tricky for GPs. It is estimated that up to 99% of women are prescribed medication during pregnancy.
That's quite a staggering statistic. Presumably some of those are for limited acute conditions, but there'll still be a lot of chronic disease management in there as well.
Yeah, so in terms of what NICE says that drugs should only be used in pregnancy only if the expected benefit to the mother is thought to be greater than the risk to the fetus. I mean, that's true of all medications. The benefit has to outweigh the risk, so must be a difficult balancing act. The fear, of course, is causing congenital malformations. The module lists some potential congenital malformations that are associated with drugs that have been used during pregnancy. For example, cleft lipped or palate with benzodiazepines, or spina bifida with sodium valproate.
So yes, unfortunately, an estimated 250 pregnancies is exposed to anti-epileptic drugs, such as sodium valproate. And all patients on these drugs who are of childbearing age need to be made aware of the potential risk of congenital malformations. And as recently as November 2023, there was a national patient safety alert from the MHRA asking organisations to put in place measures to oversee prescribing of valproate to new and existing patients who could become pregnant. So for women who have certain types of epilepsy that responds best to sodium valproate and who have good control with this drug, the risk of seizure recurrence needs to be balanced against the increased risk of fetal abnormality and cognitive and behavioural problems. And in 2021, the MHRA published a review of the safety of AED use during pregnancy, and this concluded that lamotrigine and levetiracetam are the safest of the anti-epileptic drugs included.
Thanks, Pat. Now would probably be a good time then to bring in our colleague Chloe. Chloe, MIMS have just reported on the fact that the anticonvulsant topiramate is now contraindicated in pregnancy. Can you tell us a bit about this change and why it came about?
Of course, thanks Rhiannon. So as you say, the MHRA have tightened the pregnancy safety measures for topiramate, which is used to treat epilepsy and also to prevent migraine. It was already quite well known that children exposed to the drug in utero were more likely to have congenital malformations and low birth weight. But a new safety review by the MHRA has also shown there's a potential increased risk of neurodevelopmental disorders like autism and ADHD. So the review found that the risk of congenital malformations with topiramate is dose dependent, with the incidence ranging from 4 to 9 per 100 births in children exposed to the drug, which compares with 1 to 3 per 100 in the general population. Topiramate use was also correlated with a high prevalence of infants born small for gestational age and with lower birth weights. Additionally, the review showed that topiramate might elevate the risk of intellectual disability, autism spectrum disorders and ADHD by around 2 to 3 times compared with children born to mothers with epilepsy who are not using the anticonvulsant medication. So because of the risk to the unborn child, topiramate was already contraindicated in pregnancy for migraine prevention. But as a result of this safety review, it is also now contraindicated in epilepsy unless there is no other suitable treatment. And in both indications, there's a new pregnancy prevention programme which states various conditions that must be adhered to.
Yes, so as a quick reminder then for the listeners, the pregnancy prevention programme requires assessment of the patient's potential for pregnancy and a discussion with them on the need for the pregnancy prevention programme. Pregnancy testing prior to the initiation of topiramate, informed patient consent about the risks of topiramate use, in this case in pregnancy, use of highly effective contraception during and for at least 4 weeks after treatment, completion of the risk awareness form with the patient to be repeated at each annual review, and for a copy of the patient guide to be provided to the patient or to the responsible person. So, Chloe, does this also apply to sexually inactive women or women who, for other reasons, are not going to be getting pregnant?
It does. So these conditions apply to sexually inactive female patients unless, as the MHRA says, the prescriber determines that compelling reasons exist indicating there is no risk of pregnancy. And it's also really important for healthcare professionals to identify women and girls of childbearing potential who are already using topiramate and invite them for review to make sure that they are meeting the conditions of the programme.
So what do healthcare professionals need to be telling their patients then if they are bringing them in for review and counselling on the use of this drug?
So a key part of the pregnancy prevention programme is making sure that patients understand the risks of the drug in pregnancy. And the MHRA says that when counselling patients, healthcare professionals need to emphasise the importance of using effective contraception throughout treatment and for at least 4 weeks after their last dose, and also being aware that topiramate may interact with some hormonal contraceptives. If they're taking topiramate for migraine prevention and they think they might be pregnant, they should discontinue the drug immediately and contact their GP. If they're taking it for epilepsy, they should consult their GP or specialist if they think they may be pregnant before stopping the drug, because obviously abruptly stopping the drug could increase their risk of seizures.
Thank you, everyone. I feel like we've covered a lot in that discussion. What were your key takeaways from today, though?
Like you, I was really surprised to learn that ectopic pregnancy cannot be studied in animals because it's a virtually unique human phenomenon.
Yeah, and I think it's interesting that if you are pregnant, you're extremely likely to be prescribed a drug during pregnancy, and that there is still a need for organisations to take action on the risk posed by sodium valproate.
The really interesting fact I learned was that for every 1% increment in HbA1c in the first trimester, your risk of pre-eclampsia increases by 60%. So I think this really drives home why preconception counselling is so important. Thank you so much for joining us. In next week's episode, Dawn will hear from Dr. Sandhya Raman about lifestyle interventions with a focus on how these might apply to South Asian people. So that is one not to miss. Goodbye for now.